today's program, for the morning session at least. So altogether we will have 4 defenses in the field of orthopedics. So the order is Orsolya Gresic, Luca Hergár, Krisztián Kovács, and Viktor Veninger. And now I would like to introduce you our international guest, Professor Ling Qin from the Chinese University of Hong Kong. Thank you for accepting our invitation. Professor Ling's one of the most well-known innovation is the magnesium containing implants, and also the publication has been cited more than 1,000 times. And also the other committee members, I would like to introduce you Imre Antal from Semmelweis University, Krisztián Sisek from the University of Szeged, Imre Szeb from the Semmelweis University, László Bucsi from the Szent György County Hospital, Székesfehérvár, Miklós Szendrői from Semmelweis University, and also we have a statistician colleague here in the committee, Boglárka Szentes, and the methodology supervisor, Bianca Golzio. Also, I would like to ask you, if you have any questions, then please feel free to have also statistical questions as well. Thank you.
Dear members of the committee, dear audience, thank you for being here today. It's an honor to present you my thesis, Translational Key Points between Radiology, Physical Examination, and Hand Surgery. My name is Luca Hergár. I'm a resident doctor at the Department of Orthopaedics and a PhD candidate at the Center for Translational Medicine. My supervisor is Judith Réka Hetési, and my vision is to improve diagnostic efficiency in hand surgery, and my mission is to assess the reliability of imaging techniques and physical examination in hand surgery to discover the points where efficacy might be improved. Throughout my studies, I had 2 specific goals. Firstly, investigating the diagnostic accuracy of magnetic resonance imaging for ligamentous regions around the wrist, and secondly, assessing the correlation of 2-point discrimination and electroneurography in carpal tunnel syndrome. Evidence-based medicine provides a framework for treating patients based on their values, our clinical expertise, and the best available scientific evidence. The aim of translational medicine in one sentence is to bring back scientific knowledge to the bedside, and this is what we had in mind throughout our research work. Wrist MRI is a widely used diagnostic tool in everyday clinical practice. And we have decided to perform a systematic review to synthesize the results of previous studies. Following established scientific guidelines had utmost importance throughout our research work to provide high quality of evidence. To assess the correlation between 2-point discrimination and electronography in carpal tunnel syndrome, we have designed a comprehensive protocol for this prospective study, and we are convinced that these efforts contributed to the generalizability and the validity of our findings. And now I would like to present my first topic, no evidence for the superiority of 3 Tesla MRI over 1.5 Tesla MRI for diagnosing wrist ligamentous lesions. Wrist soft tissue injuries are common pathologies. The gold standard diagnostic tool for these injuries is wrist arthroscopy. However, this is an invasive method with limited availability. Therefore, reliable non-invasive imaging is necessary for optimal treatment planning. MRI has a crucial importance in the diagnosis of triangular fibrocartilage complex, scapulohumerate, and lunotriquetral ligamentous lesions. But the question is, can we really rely on MRI? In the literature, the diagnostic accuracy of wrist MRI varies between 60 and 98%. This is a wide range. And this led to our research question, what is the sensitivity and specificity of wrist MRI? And are there any technical and anatomical factors influencing the accuracy? In our study, we concentrated on special technical factors such as the field strengths, the use of wrist coils, 3D gradient echo sequences, and the use of fat saturation. Studies reported different sensitivity and specificity values based on anatomic location. So this was also another factor that we have considered during our research work. The aim of our study was to compare the sensitivity and specificity of wrist MRI to wrist arthroscopy and to evaluate the effect of both anatomical and technical factors on diagnostic accuracy. Our hypothesis was that the diagnostic accuracy of MRI is close to arthroscopy and that there are certain factors that decrease or increase the diagnostic accuracy of MRI. Studies were screened for eligibility based on the PICO framework. We included papers reporting about adult patients with suspected ligamentous lesions of the wrist. The intervention was wrist MRI and it was compared to wrist arthroscopy, and the outcomes were sensitivity and specificity. Our study protocol was registered at the Prospero database, and the systematic search was conducted on the 22nd of October 2021, and it was updated on the 12th of February 2024 using Central, Embase, and Medline databases. And the study was conducted according to the PRISMA guidelines. At the end of the selection procedure, we have found 37 eligible studies. On this slide, you can see the overall sensitivity and specificity of the MRI. And the sensitivity was 74% and the specificity was 84%. On this slide, you can see the effect of different technical factors on the sensitivity and specificity. You can see that the highest sensitivity was at 1.5 Tesla MRI, while specificity increased with the increasing field strengths. The use of wrist coils and 3D sequences had a positive effect on sensitivity, while specificity remained nearly the same. On the other hand, fat saturation seemed to improve the specificity. But if you take a look at these results, you can see that the confidence intervals are overlapping. So we performed two-tailed z-tests, and we have confirmed that these differences were not significant. As we examined the anatomical factors as well, we have found that the best results were achieved for central and peripheral tears of the TFCC, where the sensitivity was 86% and 90%, while specificity was quite high. It was 95%. For scapholunate ligamentous lesions, the sensitivity was 63%, while for lunotriquetral ligamentous lesions, it was 41%. But in both cases, the specificity was quite high, 86 and 97%. When we take a look at the likelihood ratios, we can see that for scapholunate ligamentous lesions, there was a difference between 1.5 and 3 Tesla MRI imaging. The 3 Tesla imaging had a considerably higher positive likelihood ratio, and the negative likelihood ratio was also substantially lower. So this shows us that in the case of suspected scapholunate ligamentous lesions, the 3 Tesla MRI might be more accurate, but again, these differences were not significant. The risk of bias assessment of the included studies was conducted according to the QUADAS-2 tool. The risk of bias arose in most cases due to inconsistency in patient selection and the flow and timing of the studies. We have performed a subgroup analysis where studies with high risk of bias were excluded from the analysis, but we have found that it didn't significantly change the results. We have also performed the grade assessment. It showed a low quality of evidence. This is most likely linked to the study designs. In conclusions, we have found that the best results were achieved for TFCC peripheral tears, and we have found that technical factors seem to influence the accuracy of wrist MRI. 3D sequences and wrist coils increased sensitivity, while field strength and fat saturation increased specificity. However, these differences were not significant. Overall, our study found that no evidence for the superiority of 3 Tesla MRI over 1.5 Tesla MRI regarding the diagnostic accuracy. However, I have to mention that our study was limited by the heterogeneity of the included studies. In summary, MRI was found to be a reliable diagnostic method, and further research is suggested to evaluate the differences between 1.5 Tesla and 3 Tesla imaging for suspected scapholunate ligamentous lesions. And now let's move on to the second topic, assessing the severity of carpal tunnel syndrome during physical examination by measuring two-point discrimination. In carpal tunnel syndrome, the median nerve is under compression, causing motor and sensory deficits. Nerve conduction studies, electromyography and electroneurography provide an objective and quantifiable evaluation of the nerve dysfunction. During physical examination, two-point discrimination was found to be a useful clinical method to examine the sensory function. The aim of our study was to define whether 2PD measurements could be used as a screening method to assess the severity of carpal tunnel syndrome based on its correlation with electroneugraphic values. Evaluating the degree of severity of carpal tunnel syndrome is important to determine the urgency for further testing, appropriate therapy, and also for follow-up. And the hypothesis of our research was that there is a correlation between 2PD and electroneugraphic values. We included adult patients who underwent surgery for carpal tunnel syndrome at our institution. The intervention was two-point discrimination measurement, and it was compared to electroneugraphy, and the outcome was the degree of severity of carpal tunnel syndrome. Data collection took place at the Department of Orthopaedics at Semmelweis University between September 2015 and June 2019. The severity based on 2PD values was decided as it's shown here. So below 6 millimeters it was considered normal, between 6 and 11 millimeters it was considered elongated, and over 11 millimeters it was considered severe. The severity based on the nerve conduction studies was defined as mild, moderate, or severe severity, and it was decided by the examining neurologist. The study followed the Strobe recommendations, and it was conducted in accordance with the Helsinki Declaration. We have found a significant correlation between 2PD severity and the severity of electroneugraphy, as well as 2PD values and the severity of electroneugraphy. In these two figures, you can see the distribution of 2PD values based on ENG and EMG severity categories. Figure 6 shows mild, moderate, and severe categories. And figure 7 shows severe and non-severe categories. We have found that 2PD has a more important power to indicate a potentially severe carpal tunnel syndrome, and it had a better potential to distinguish between these two categories rather than the three. And we wanted to find the point where the accuracy is the highest, and this point was defined at 9.5 millimeters. At this point, the accuracy was 69%, the sensitivity was 65%, the specificity was 71%. And at this point, the diagnostic odds ratio was 4.68, meaning that patients who had 9.5 millimeter of 2PD value or above this value had a 4.68% higher chance to have severe carpal tunnel syndrome. Overall, we found that there is a significant correlation between 2PD and the severity of carpal tunnel syndrome based on EMG examination, and the highest diagnostic accuracy for carpal tunnel syndrome was achieved at 9.5 millimeter cutoff value. The sensitivity and specificity of this examination remains lower compared to the ENG testing. However, as 2PD measurement is a quick and easily applicable diagnostic method, it has the power to act as a screening examination for potentially severe carpal tunnel syndrome. And as it's an objective and cost-effective method, it makes it ideal for follow-up evaluation of the sensory function of the hand as well. In summary, this prospective cross-sectional study has examined the severity of carpal tunnel syndrome by two-point discrimination measurement. And the validity of this screening method was confirmed through the significant correlation between 2PD and the results of electronographic studies. The highest diagnostic accuracy was achieved at 9.5 millimeter cutoff value. The presented studies got published in May and in September in 2024. And I have also co-authored these publications during my doctoral studies. With Dr. Hetishi, we have presented the results of these studies at several international conferences. And during my doctoral studies, I had the honor and privilege to participate in the Musculoskeletal Research Fellowship at Massachusetts General Hospital, and also at the Translational European Asian Hub for Excellence Scholarship at the Chinese University of Hong Kong. Both these fellowships had markedly contributed to my knowledge about high-quality clinical research projects, and I'm happy to share that the collaboration is still ongoing with these prestigious hospitals and universities. I would like to thank for your attention with a quote from Antoine de Saint-Exupéry: "A goal without a plan is just a wish." So at the end of the presentation, I would like to thank everyone who contributed to the doctoral studies and helped my plan to achieve my goal. And I would like to thank you very much for my supervisor, Judith Hetishi, as well, for her continuous support throughout this scientific journey. Thank you very much.
Thank you, Luca. Now it's time for Q&A.
So I have two questions regarding the first research. The first one, you compared the sensitivity and specificity of MRI to arthroscopy. For me, that seems to be a little controversy in it, because the MRI is a diagnostic tool and arthroscopy is a surgical procedure. How could you release this controversy if you see the same, that is, one is a diagnostic tool, the second one is a surgical procedure?
Thank you for your question. It's a very important point that you raise here, that currently the gold standard diagnostic tool is actually an intervention as well. So the reason behind this is because MRI provides a static image that we can see. Of course, there are different modalities, and when we can assess the movements of the wrist as well. But this is the availability of these methods is very limited. So in the literature, we can see that only by looking directly at these ligaments, we can determine whether there's an important instability and the degree of potential injury of these ligaments. But as you mentioned, the idea would be to have a non-invasive diagnostic method when we can look at the results and determine whether we need to do the intervention or not. And this is why we thought that it's important to look at how can we optimize the results of the wrist MRIs, what are the factors that contribute to the best results, when we can say for certainty if they need an intervention or not.
According to my opinion, it can be accepted, the comparison, if the arthroscopy is followed by a surgical treatment as well. Otherwise, it's a very, very interesting viewpoint. But altogether, if you consider nowadays the orthopedic surgery, just the arthroscopy is not widely accepted for the diagnosis. That if it is followed some surgical intervention, that is accepted. My second question is that what is your opinion about involving the ultrasound for the neural lesions, for the diagnosis of neural lesions? Because nowadays, that was a surprise for me, there are a few real good ultrasound specialists in Budapest and in Hungary who say they can help us to diagnose the neural lesions in the hand region as well. And maybe the ultrasound is widely available for the patients and for the researchers comparing to MRI. So.
Yes, ultrasound is also the use of ultrasound is more and more increasing, and it's very good news for us because, of course, if it's available, then it can be more easily arranged than MRI imaging. I think for neural lesions, for example, for carpal tunnel syndrome, it contributes to the diagnosis at an important rate. However, the imaging of the ligamentous lesions is maybe ultrasound is not the best for that because these are very small structures and it's not so easy to distinguish and to find the lesions, or at least according to the discussions I had with the experts who use ultrasound regularly. But yes, with the higher resolution technique, maybe in the future this will be a possibility as well, and it would contribute to the more straightforward diagnostic procedure.
So we can believe the ultrasound specialist in the future, not nowadays.
Yes, maybe it also depends on the technique that is available. So with higher resolution, we have hope that in the future it will be a tool to use.
Thank you very much. Thank you.
As your opponent, I have to say that it was a real excellent work. I have some few questions according your study. First, your meta-analysis showed that the accuracy of the MRI examination depends slightly, but not significant, from the technical conditions of the MRI. 3 Tesla and 1.3 Tesla. But what's about the educational level of the radiologist who performed this study? Are there some inter-observer studies about this? What do you think? Have you found this?
Yes, thank you for your question. We have included 37 studies, and out of these 37, there were 7 studies where they used, or where 2 radiologists evaluated the imaging. In the overall results, we have chosen randomly the evaluation that we included, but we have also performed subgroup analysis when we compared the expert opinion to the fellow opinion. And there was no significant differences. Of course, by individual studies, in some cases, they have found that the radiologist who had more experience had a higher or a more accurate evaluation of the MRI imaging. So this is also something to take into account when we receive a description about the MRI, if it was evaluated by someone who had more experience or by someone who had less experience. Now in radiology as well, there is a musculoskeletal specialization when the radiologists focus on the lesions of the musculoskeletal system. So if we can collaborate with them, this is very likely that their results are more accurate, as this is a very special field.
Okay, thank you. The second question would be, based on your meta-analysis, from now on we can use, beside the electrophysiological measurement, also the simple 2-point discrimination test for the estimating the seriousity of the CTS. But what's about the MRI? What do you think, is MRI either 1.5 or the 3T equipment suitable to distinguish between the mild and more severe form of CTS through detecting ödem degeneration, thickening of the median nerve?
I think it can be a useful method as well. Of course, we are limited by the availability of the MRI. So as carpal tunnel syndrome is a very common disease, 10% of the patients who come to the hand surgery outpatient clinic have carpal tunnel syndrome, and we don't really have the availability of MRI to have them examined by this diagnostic modality. And also there might be a discrepancy because often when the symptoms occur, they can be very pronounced symptoms with synovitis and increased edema. And as the disease progresses, these symptoms can decrease. However, the nerve compression is still there, causing more and more damage to the nerve. So it's possible that in case of a carpal tunnel syndrome that's been going on for several years now, the nerve damage is more pronounced, even though that the anatomic changes are not so pronounced. So this is why the nerve conduction studies have a higher importance in the diagnostic procedure, because they can give an objective evaluation about the nerve function, while maybe the anatomical imaging might be a bit misleading. But also in the literature, MRI is advised in the diagnostic procedure in case of secondary carpal tunnel syndrome. So when we have the suspicion that there is a space-occupying lesion, tumor-like lesions, or for example, a pronounced ganglion that might contribute to the nerve compression, or if we have performed the carpal tunnel release and it's not improving as we thought that it should be improving. In these cases as well, MRI has a very important role in the diagnosis and in the differential diagnosis as well.
So do you think that the MRI shows only a morphological changes, but the electrophysiological changes and the two-point discrimination test is maybe more connected with the functional outcome and with the disease seriousity of the disease?
Yes, I think so.
Okay, thank you. And how much influence the educational level and occupation of the patient? For example, it's a hand worker or typist. The sensitivity of the two-point discrimination test. What do you think about this? Can influence the outcome of your test?
Yes, for the educational level, I haven't seen studies that measured this, but the profession, the occupation of the patient had a very important influence on the two-point discrimination measurements in both ways, because there was a study about chiropractor students, and that they have measured the two-point discrimination at the beginning of their studies, at first year, and also at the 5 years. So as they were trained with their hands, they found that the two-point discrimination actually increased throughout their studies. So there is this positive effect as well, and also patients who are working with vibration tool, for example, with construction workers, the vibration is known to damage the smaller nerves. So we can expect more elongated 2PD values. In this case, I think it's important to measure two-point discrimination, not only the first 7 digital nerves, but also from 8 to 10, based on the ulnar nerve territory. So this way we can compare these results, and we have to ask patients about their occupation to know what to expect when we are performing this examination.
Thank you. My last question is connected with the previous question. How do you can explain that there is no relationship between the peripheric ultrasound and the two-point discrimination test in the carpal tunnel syndrome?
I think it's a bit related to the MRI findings as well, that in the beginning of the symptoms we can see more important edema and more increased cross-sectional area of the median nerve. And while symptoms can last for a longer time, this initial synovitis can decrease. So the two-point discrimination measurement is more in connection with the functional evaluation that we can see during the nerve conduction studies as well. And during the ultrasound examination, we can't say for sure that more pronounced symptoms equal with the worse functional status of the median nerve.
Okay, thank you very much.
Thank you.
Yeah, thank you, Mr. Chairman. First of all, I would like to congratulate highlighting your D1 publication in arthroscopy, which is absolutely fantastic for me. Going through your thesis, I have only one question. from my side concerning the implementation for practice. In winter time, on a certain days, there are hundreds of wrist injuries turning up on OPD in traumatology. What do you think about this protocol? How to edit this protocol for general orthopods to send patients for MRI scan when you have hundreds of patients in the outpatient department to find out whether there is any ligament injury or not?
Thank you for your question. It's a very important point that you raise, because of course we can't send everyone to an MRI. These ligamentous lesions are often related to other injuries as well. So, for example, a distal radius fracture. And when we are treating the distal radius fracture during the conservative method with plaster and splinting, sometimes these ligamentous tears can heal as well during the time that the fracture itself heals. And if you choose the operative method, the osteosynthesis, and then at some practices, for example in Hong Kong, what I saw is that they use wrist arthroscopy during the osteosynthesis. So this has two positive points. I think is that we can check the alignment of our osteosynthesis. So for there is not even a millimeter difference in the level of the bone fragments, and also we can visualize directly the ligaments. So if we see a ligament tear, in some cases maybe a direct reconstruction is also an option, and if not, then maybe for a bit longer immobilization, it can also be a possibility. So this is one option. And also, I think it's important to follow up these patients, because often when they have another traumatism, for example, a distal radius fracture, then this is the main complaint. But as we follow up, then weeks later, when the fracture is healing and it's already in a good shape, if they still have persisting symptoms, then we can think of doing an MRI and to investigate further if there is a ligamentous lesion in the background.
Thank you.
Thank you. Congratulations on your fellowship. I'm sure it has changed your perspective in going to Harvard for a year, and I'm sure it will change in the long term in your research. I wanted to ask about the 2-point discrimination test. Are you aware on the observer side? So whoever is doing the examination, are you aware of any intra-observer or inter-observer differences of how you perform this test? And my second question is regarding the 9.5 millimeters. You listed 3 groups below 6, 6, 11, and 11 plus. So is this a statistical number that has been generated with all the results pooled, and then you just made a cutoff point, or could you comment on that? Thank you.
Yes, thank you for your question. So in this study, I was the one who performed this 2PD measurement, so it was the same standard measurement that throughout the study. So how it looked like is that first I showed patients how the test looks like, that they were going to feel 1 or 2 points, setting the distance to the highest to show them what 2 points feel like, and explain the examination in detail. I think it was also important that I asked them not to look at the examination that I'm performing, because this can also influence the values. If they see that there are 2 points that are pressing on the finger, then they can they tend to say that it's 2 point, even if they are on the border of feeling 1 or 2 points. But you are right that in the literature as well, I have seen several studies when there were 2 evaluators, or they used a different methodology, or they evaluated 2 times the values. This is something to address during the publication. We were transparent with our method in the publication as well, but yes, there might be differences based on how this examination is performed. And regarding your second question, yes, we had this hypothesis, or this initial approach to have three severity categories for mild, moderate, and severe categories, because this is the way it's also done during nerve conduction studies. And we wanted to see if these three categories overlap and if there's a significant correlation. And we have found that there is one, but it's not exactly as the way we thought. So to find a cutoff value, it was not really possible to find a cutoff value for these three categories, although we have seen that the values change. So there is an increase in two-point discrimination measurement at the same time, and there is an increased severity. And we have found that the 2PD evaluation is the best if we want to distinguish between severe and non-severe categories. This is where we find this 9.5 millimeter cutoff value. Because we had the severity categories, but also the 2PD values. And when we had all these examinations together, the way we did is that we combined the mild and moderate severity based on the nerve conduction study, and we had the severe cases. And we found it might be useful during the physical examination as well, because this way when we screen for patients and we see that this might be a severe carpal tunnel syndrome, then we can accelerate the further testing, and we can operate on these patients more quickly. So then we can decrease the effect of permanent or possibility of permanent nerve dysfunction.
Two questions, or not really question, comments. So one is the same as the previous one. So how the first study benefit the second?
Yes. Thank you for your question, Professor Chin. Yes, it's true that these are two different studies. The bridge between them is that they are both linked to the diagnosis, one from the radiological side and one is from the physical examination. We use these methods during the evaluation of our patients. And I think they are both, the aim of both studies was actually to help with the surgical indication of these patients. So one for the wrist ligamentous lesions and one is for the carpal tunnel syndrome. And the aim of our work was to make the indication clearer in these cases.
Okay, thank you. The second, definitively congratulations, the same for the first candidates to publish the two papers. My question behind is that apart from our examiners' questions, could you still recall the major challenging questions from the reviewers for particularly the number one paper? Because normally we know to publish negative findings is more difficult than to publish the positive findings. Could you still recall what are those ones, name one or two, and how did you address that?
Yes, thank you. It's also a very interesting question because it's actually the first time the article was rejected from a journal, and then after revision it was accepted to another journal. It was Arthroscopy, which made us very happy as well because it's a prestigious journal. I think the most important question what they rose was about the subgroup analysis. As Professor Sandri mentioned as well, the difference between the educational level of the evaluating radiologist and also how the randomization of these experts was done, who we decided to include in the overall analysis. And I think, yes, this is what was their main question is about the subgroup analysis based on the different aspects, technical aspects and anatomical aspects that we have decided to perform.
So last challenge, right? Basically,
Yes.
Education is important in the observations, definitively. So since you conducted this study to compare 1.5 versus 3 Tesla, the comparison. So what was your study hypothesis behind? What would you expect from this? Definitively expect positive results, more sensitive, right? And then came up with no evidence to show. What could be the major explanations if the review did not ask for your paper?
Yes, it was definitely a surprise for us as well, because we thought that with the higher field strengths we can expect better results. As one of the reasons might be that with higher field strengths also the inhomogeneity of the magnetic space is it increases, so there might be some errors or in this evaluation. Also, the other thing is with the we might perceive injuries or other variations that are not necessarily linked to the complaints. So, for example, an intraarticular ganglion cyst, and then it can derail a bit our thinking, and not just focusing on the ligamentous studies. So it's something to investigate further while this discrepancy exists, but this is actually, as you mentioned, at Harvard as well. My supervisor had the same experience actually, that 1.5 Tesla is just as good as 3 Tesla MRI in the diagnosis. And it might also come as a relief for us, so we don't necessarily have to aim for the 3 Tesla imaging if with 1.5 we can already see the important lesions.
Yes, important findings, of course, probably the availability of the machine as well as the costs. I do not know where the difference is. So the healing stages, disease stages, staging could also have influence on the final assessment, I guess. Okay, thank you, please.
A very last question from my side. What are you seeing based on your study that the 2-point discrimination test could replace in the future the electrophysiological study? It would be very cost effective in the everyday practice, or it's still important, the electrophysiological study?
I think I don't think it will be able to replace the nerve conduction testing because there might be several reasons behind the elongation of the 2PD value. For example, patients with diabetic neuropathy or patients receiving chemotherapy that also destroy the smaller nerves. So it's not so specific for the carpal tunnel syndrome, and also it was not as sensitive and specific as the nerve conduction studies. But there is a tendency in hand surgery as well. Before they advised in every case to do the nerve conduction studies, and nowadays it's more they advise if we have, in case of doubt, if we have doubt of thoracic outlet syndrome or more proximal compression of the median nerve, and so if, maybe in the future if we are more relying on the results of the physical examination, then in select cases it might be sufficient. But if we want to have a comprehensive evaluation of the nerve function, then I think we still should perform the nerve conduction studies.
Okay, if no further questions, I think again, congratulations. We conclude in these 2 candidates' oral defense, and we will have committee discussion about the rating. Just wait here a couple of minutes. We will come back and announce the evaluation results.
Thank you very much.
Okay, thank you. Call Luca. So also congratulations. We all agree with good results with almost a full mark, 4.97. That is 99%. Congratulations. The panel discussed all the presentations. We are very impressed by your good performance. Particularly, we experienced all your 7 exercises before, right? And this is 8th time. Really so amazing about your contributions. Although we realize that this work is mainly meta-analysis published by others, but it is important, as Professor Haiti already mentioned, to turn the knowledge into application. Sometimes the original authors may just conduct a study and publish. How to promote their findings? Of course, the meta-analysis evidence level is much higher. So your conclusion, including just M1, for example, the comparison 1.5 versus 3 point, Tesla studies, eventually no difference. So we know it bears significant clinical impact for our general applications. The same as well for all of our studies here to look at those the findings, although with negative findings, but we also know, for example, the application of the toxin injection have beneficial effects, but we know the time window for measurement is important for future prospective studies, how to plan those studies well to provide more evidence-based results is really helpful with all your contributions here. Congratulations again.